Before the year 2000, treating connective tissue disease-associated interstitial lung disease relied on educated guesswork. Clinicians threw high-dose steroids and broad immunosuppression at a deteriorating lung, and the outcomes were highly variable. Today, the treatment algorithm is a sequence of logic gates. Each drug is positioned based on a specific data-backed rationale derived from the last 20 years of clinical research. Looking at this blank clinical framework, we can see how the modern algorithm was built. Every landmark trial over the last 2 decades was designed because it solved the specific clinical failure of the trial that came immediately before it. We can trace a direct line from proving that toxic induction therapy worked, to establishing safe maintenance protocols, to the introduction of targeted antifibrotics, straight through to today's combination therapies. Mastering the treatment of CTD ILD requires knowing exactly how that chain of evidence snapped together. You have to understand how the field moved from blind empirical suppression to precision phenotype targeting. The modern evidence base begins in 2006 with the Scleroderma Lung Study 1. Its objective was simple: to prove, in an adequately powered randomized control trial, that scleroderma ILD could actually be treated. Over 12 months, oral cyclophosphamide improved forced wild capacity by 2.5% compared to placebo, stabilizing CT scans. But patients suffered severe toxicities: leukopenia, infertility, and bladder toxicity. Once the toxic drug was stopped, the lung function benefits vanished. An earlier European trial, the FAST trial, had attempted to solve this fading efficacy by following IV cyclophosphamide with azathioprine. While underpowered, it introduced the necessity of maintenance therapy. This unresolved tension between efficacy and toxicity dictated the design of SLS-I in 2016. The specific question was, could a safer drug match the lung function benefits of cyclophosphamide? Comparing mycophenolate mofetil against cyclophosphamide, you see 2 nearly overlapping lines over 24 months. Both improved lung function equally, but MMF had drastically lower toxicity and discontinuation rates. Clinicians finally had an effective induction agent that patients could tolerate long-term. SLS-II answered the question left by SLS-I. It established MMF as the first-line standard for both induction and maintenance, and permanently pushed cyclophosphamide down the algorithm into a rescue therapy role. Immunosuppressive drugs work by shutting down inflammation, but once active inflammation gives way to established fibrosis, those drugs lose their target. The disease shifts pathologically. Early ground glass opacities turn into rigid, irreversible architectural distortion. At this stage, suppressing the immune system no longer halts the decline. This mechanical failure required a completely new pharmacological mechanism. In 2019, the Census trial shifted the focus away from the immune system and directly targeted the fibrotic cascade using nintedanib. Census was the largest SSc-ILD trial ever conducted, specifically focusing on a population where high-resolution CT scans showed over 10% fibrosis. At 52 weeks, patients on placebo lost 93 milliliters of lung function. Nintedanib patients lost only 52 milliliters, a 44% slower decline. It acts strictly as a brake. Crucially, a subgroup analysis proved that background MMF immunosuppression did not negate this antifibrotic efficacy. This analysis provided the first high-quality evidence that adding an antifibrotic to background immunosuppression was both safe and effective. Census redefined clinical expectations. It proved that while fibrosis cannot be reversed, it can be pharmacologically slowed down in conjunction with baseline MMF therapy. Before 2019, clinical trial design and daily prescribing habits were strictly partitioned by the underlying autoimmune disease label. A rheumatoid arthritis patient and a Sjogren's patient were treated differently based on their primary diagnosis. The INBUILD trial discarded that logic entirely. INBUILD grouped distinct diseases like rheumatoid arthritis and myositis under a single umbrella, progressive fibrosing ILD. Results showed consistent FVC decline reduction across all diseases using nintedanib. This proved that a progressive fibrosing phenotype will respond to an antifibrotic, regardless of the autoimmune trigger. By proving that pathogenic behavior trumps the diagnostic label, INBUILD redefined how clinicians select salvage therapies for fibrosing lung disease. While Census and INBUILD addressed late-stage fibrosis, another trial focused on the opposite end of the spectrum, the highly inflammatory early diffuse SSc phenotype. This was the FOCUS-S trial for tocilizumab. You can see on this trial dossier that FOCUS-S had a paradoxical result. Its primary endpoint was reducing skin thickening, and it statistically failed. However, the secondary endpoint revealed a significant signal. In this specific subgroup of patients with early inflammatory disease and high CRP levels, tocilizumab effectively preserved lung function. The preservation of forced vital capacity was so clinically meaningful that the FDA ignored the failed primary skin endpoint entirely and approved tocilizumab to slow SSc-ILD progression. But what about patients who present with severe, rapidly progressive disease across various CTD ILDs? These patients need aggressive induction, but cyclophosphamide carries heavy toxicities. The 2023 RECITAL trial tested rituximab against cyclophosphamide in severe diseases. The comparison table shows matching efficacy and improving lung function, but rituximab achieved that improvement with a significantly lower burden of adverse events, making it a highly effective alternative. Together, FOCUS-S and RECITAL validated the use of IL-6 and B-cell targeted biologics, arming clinicians with precision tools tailored for the inflammatory extremes of the disease. We are now moving past isolated monotherapy. Emerging data, like the EVER-ILD trial, increasingly supports early combination strategies, such as pairing MMF with rituximab to better preserve lung function. Looking at the modern clinical algorithm, we can map exactly where these trials fit. For the early inflammatory phenotype, SLS-I dictates MMF as the preferred first line, while FOCUS-S provides tocilizumab as the targeted alternative. If a patient presents with rapidly progressive or severe overlapping disease, the RECITAL trial directs us towards rituximab, keeping cyclophosphamide in reserve. And if the disease progresses to a fibrotic phenotype despite immunosuppression, the Census and INBUILD trials guide our next step, introducing nintedanib. Based on the crucial subgroup data, that antifibrotic is added to the background MMF. It does not replace it. Today, CTD ILD management uses a phenotype-driven combination strategy constructed from 2 decades of iterative trial deductions.